You are now listening to Nailed It, the Orthopedic Surgery Podcast.
We're back with Adult Reconstruction Citation Classics, Episode 2, with a topic, highly debated and highly discussed, which is approaches for primary total hip arthroplasty, with a focus on direct anterior and posterior approaches. This is something that all orthopedic residents, whether or not they're going into joints, will be asked by family members, friends, patients. What approach does the attending do? What approach do you do? Which approach is better? And it's important that we're familiar with the literature and the complications associated with either approach. And so we chose some papers that are, at this point more historic, but do highlight the nuances and unique complication profile associated with either approach. And we'll go ahead and get things started with the emphasis on capsular repair and posterior total hip arthroplasty with Kaihui Zhu presenting.
Yeah, so the first study we have, the title is The Surgical Approach Affect Total Hip Arthroplasty Dislocation Rates. And this study was done by Kwan and their team at UVA. And this was published in 2006 from the Clinical Orthopaedics and Related Research. So we have some background information about the study. Typically with dislocations after the posterior approach, it's roughly 3%. And most of the hip dislocations in the THA is usually from the posterior side. And usually what happens in this situation is when the hip goes beyond the soft tissues when you're doing that approach. So regarding the study, the purpose is to look at the dislocation rates of various different approaches, such as the posterior, with and without breaking, without the capsular repair, and comparing that to the direct as well as the anterior approach. So regarding the methods of the study, they did a systematic review and meta-analysis, and they found 11 studies reporting various dislocation rates of a primary total hip arthroplasty. Regarding the posterior approach, they found 5 studies with roughly 4,000 patients in that regard. In addition, with the anterior and direct approach, they found roughly 2,000 in each of these studies. So looking at the results, when you have a posterior approach, THA, with the repair of the capsule, you have a roughly 0.49% dislocation rate. With a posterior approach without a repair, it's has a higher dislocation rate at a 4.46. And with the anterior and direct approach, they have a dislocation rate of 0.7 and 0.43 respectively. So regarding conclusions of this paper from this analysis, it showed that the posterior approach with the capsular repair has a lower incidence of dislocation compared to the approach without the repair. And so, regarding future practices when you're an orthopedic surgeon, when you're doing a total hip arthroplasty, which is a very common procedure, and when you're doing the posterior approach, more likely than not, you want to repair the capsule so that you can prevent a future dislocation from the hip. And these are some of the limitations that we had from this study, especially when it's a meta-analysis.
Nice, yeah. So I included this paper because it's a simple but important thing. So they were not looking at direct anterior approaches in this study. So it was a meta-analysis of posterior approach total hips compared to anterolateral and direct lateral, which are honestly at this point in time more historic approaches. But it was published in 2006 before the DA approach or direct anterior approach became ubiquitous or highly utilized, I would say. And so anybody who's been in the OR during a posterior hip knows that we do a lot of stability testing intraoperatively, and all of that is without the capsule being repaired. And so this just shows how much more your stability improves once that capsule is repaired. I mean, an 8.2 times relative risk. And important to note in this cohort, their inclusion criteria for the meta-analysis had a minimum of 6-month follow-up, and majority of hip dislocations occur in the first 6 months. which is probably why they included that as one of their criteria. And, you know, 0.5% dislocation rate in a posterior approach with the capsular repair is a highly successful surgery. And so for all the people that want to argue that the DA is more stable, I like this number. Obviously, I'm biased because I come from a posterior heavy residency. So the main take-home point for this article is the importance of the capsular repair in a posterior approach. And obviously, the same is true if you're doing hemiarthroplasty or total hips for fractures.
Yeah.
Hassan, have you seen the same thing in your?
Yeah. I was just gonna add, like, a lot of times when we're wrapping up with the case, doing it posteriorly, we're working on closures like deep to superficial, and we're gonna be closing capsule, and then eventually we're gonna be trying to tag back the short external rotators, I've had discussions where throughout the case with the retractor placement, sometimes the short external rotators aren't looking so great, but I think the paper kind of argues to the point that maybe the capsule repair is even probably more important than tacking back the short external rotators. I don't know if some of you you've experienced that kind of situation where your short external rotators are just not looking that great to kind of tack back on, but as long as your capsule's on there nice and good, I think that's actually a more important piece of this whole thing.
Yeah, it's interesting because I think a lot of people do not differentiate. So, I mean, we take capsule and rotators together and we consider all of that as the repair. And I'm trying to look in their criteria. That's the problem with, these kind of meta-analysis studies. There's no granularity and knowing the exact surgical technique. But I would venture to say that they probably included the two together. I mean, I agree. Most people would try to get some capsule over if they can't get the short external rotators. And I've definitely been in the OR, especially if you increase somebody's offset and lateralize their hip so much that you can't pull the rotators back. And then you have a crummy repair and you're like, okay, well, I hope this is stable. But yeah, no, honestly, I mean, to be completely honest with you, I've been in the OR before and, maybe when I was a 2 or something and watched somebody do a crummy repair and thought to myself, like, what's the point of even doing this? Is this better than doing nothing? But I think this data supports that it is better to have nothing.
Better to have something than nothing. Yeah.
So I don't
Awesome.
know. I like this just simple data to support the posterior repair. We can move on to the next one.
Awesome. All right, everybody. This is Hassan coming from Chicago, here at Loyola. I'm going to be talking about this next article we had. We picked this anterior versus posterior approach for total hip arthroplasty, a systematic review and meta-analysis. This is a paper out of Dartmouth by the group Lin. It was published in Journal of Arthroplasty in 2014. With time and whether that's societal pressure as well as just advancements in technologies in arthroplasty and approaches, other approaches to the hip have become increasingly more popular. One specifically, obviously, is this direct anterior approach. Many arguing lots of benefits to doing the direct anterior approach as compared to the posterior approach. Some may say there's less pain and a faster recovery given you're doing a muscle sparing or muscle splitting approach versus you're doing a muscle sparing approach instead of kind of splitting through your glute muscles when you're doing the posterior approach. Others may argue that there's greater stability and decreased risk of dislocation with kind of the same phenomena when you're not having to kind of tear through or cut through all that muscle coming in to the hip joint. Another kind of obvious advantage you'll quickly notice once you get into the OR when you're doing the direct anterior approach, you have intraoperative fluoro available. This is super helpful because especially when placed in the cup, it helps you kind of really be in an optimum location before you buy a positioning. It lets you kind of position it exactly where you want. And you can kind of see that all the way through. Where I would argue is the posterior approach requires a lot more technique and finesse with cup placement, which may be more difficult of a surgery if you're not comfortable with that. So there's that benefit of having live X-ray. And then finally, there's just some talks about less opioid use and less length of stay in the hospital for the direct anterior approach. So the purpose of the study was just to kind of compare some of these outcomes following primary hip replacements using this direct anterior approach versus the posterior approach. Again, this was a systematic review and a meta-analysis comparing those two approaches I mentioned. There were 17 studies that were looked at in this whole review, total of 2,302 patients. This was split kind of almost 50-50, but there's about 980 direct anterior patients, and then 1,100 or so posterior, and then almost 200 controls. The main kind of results were 4 of the studies favored the direct anterior approach when it came to looking at your, patient reported like pain and function. And then 5 of them said there's really no difference at all comparing the 2 approaches. Again, looking at length of stay in the hospital and dislocation rates, the direct anterior approach was noted to be, potentially superior in that realm. However, when looking at blood loss, rate of intraoperative fracture occurrence, your total operative time, where a patient's disposition is after the hospital, even placement of the cup, even though you're using the live X-ray with direct anterior, there really was no difference when you're comparing these 2 approaches. And similarly, there was a kind of a mixed bag of findings when it came to looking at, pain control, opioid requirements after. So as you'll see here, this review kind of was the first thing that kind of highlighted a theme you're going to pick up tonight, where there's positives and negatives to both of these approaches. The direct anterior approach in one person's hand may be the better approach as compared to the posterior approach in another person's hand. So I think really it comes down to your comfortability with the approach. And then I think the other important factor is know your patient. I'm sure we'll talk about this later, but each approach offers its benefits for a patient. So a patient with a larger BMI may be more beneficial to go posterior for that patient to get, to not have to fight the soft tissue. But a patient that's maybe on the relatively lower end of the BMI scale, you may be more at, feasibility with the anterior approach. So the study had some strengths. So it was a meta-analysis of, outcomes following these 2 approaches. They included a lot of cases in this, but ultimately there's still a lot to be learned and to compare these 2 different approaches, whether that's through RCTs or further research. That's all.
Really well said, Hassan. I think, stability is obviously the hot topic, in arthroplasty. I think it's safe to say, obviously we always worry about infection and total joints, but infection, instability, loosening, and total hips are the 3 most common complications corollary to infection, instability, loosening, and total knees. And that's why we're debating these approaches, and a lot of the outcomes look at stability, but there's a whole other component to that. And we're not even including things like technology. So like robotic assisted total hips, whether that's anterior, posterior, incorporating the hip spine, spinal pelvic parameters and those relationships and how the acetabulum moves with the spine. And so all these things contribute to the picture as well. And like Hassan mentioned, it's really about the surgeon's comfort. And I think, there is some data that supports this lower dislocation rates in anterior hips, but I don't think it's convincing, and from my understanding, hasn't been borne out to be superior for stability purposes. But we'll continue to trudge along with the next paper and see what we find.
This paper is titled Greater Prevalence of Wound Complications Requiring Reoperation with Direct Anterior Approach Total Hip Arthroplasty. It was written by Christensen at Lexington Clinic and published in the Journal of Arthroplasty in 2014. Authors of this study cited the increasing use of the anterior approach and noted a lack of literature comparing acute complications amongst the different approaches. So this paper reported the rate of wound complications requiring reoperation after the anterior versus posterior approach. Authors reviewed a registry of total hip replacements done by a single surgeon at a single institution from 2003 to 2014. They analyzed 1,288 posterior approaches and 505 anterior approaches. The anterior approach was used for patients with BMI under 40 and no bony deformity, osteoporosis, or abdominal pannus. The posterior approach required 2 reoperations, a 0.2% rate, versus 7 reoperations and a 1.4% rate for the anterior approach. Reasons for reoperation were infected or non-infected hematomas, delayed wound healing, or prosthetic joint infection. The reasons for reoperation were similar between approaches, but the overall rate was significantly different. So in conclusion, authors report a higher reoperation rate for wound complications after the anterior approach compared to posterior approach. The strengths of this study are standardized procedures and anticoagulation protocols. Limitations include selection bias for healthier anterior approach patients. Authors didn't really record wound complications managed non-operatively. And the surgeon used Steri-Strips, Zeroform 4x4, and tape to dress his posterior incisions, but used Dermabond and Tegaderm for anterior incisions. And the data was also from a registry.
I think this is kind of an interesting, topic to look at because obviously, it's talking about wound complications, but one of the things that patients will ask about is the scar and what it's going to look like. And a lot of times patients want this, smaller, incision in the front of the leg that the direct anterior approach offers, compared to this larger one that's going to be involved at the posterior approach. But patients aren't aware that, there's potentially more risk for complication, given the placement of that direct anterior approach incision, given lots of times patients have other soft tissue in the area. So, and that area also tends to face a little bit more increased tension than maybe you would expect. So, I mean, it's an interesting paper that, does mention like there is a greater risk for wound complications, but if I remember correctly, it's like 7 versus 2, although statistically significant. I guess I would question whether a delta of 5, is clinically significant, but I'm sure those 5 extra people, that was pretty significant for them. So, just a point to think about, like whether, although statistically important, is a difference of 5 really make that posterior approach, superior in the case.
Yeah, and I agree. And it's funny, this article popped up on the radar because it's been cited. And I'm going to jump to the other side of the fence as somebody, like I mentioned, in a posterior heavy training program. I'm sure a lot of people have jumped on this literature that, kind of puts the DA approach in a bad light because, not to knock on our own profession, but orthopedic surgeons, we tend to be creatures of habit. And once you go into practice and you're no longer in an educational environment, people want to do things the same way they've always done. And the threat of something new or better, scares people. And I think that they want to have ammo to defend why they're doing what they're doing. And if that's, one of the reasons why this is so highly cited, it makes me kind of wonder because like you mentioned, it's a total of 4 patients difference. So it's really interesting. And these guys did, one of their disclusion criteria was BMI less than 40. And, I know there's other data out there that shows BMI is substantially associated with these wound complication rates. So, there are people that do DA approaches on people who have larger BMIs, and another known risk factor for wound complications in DA hips is diabetes. And I don't think they included any information, demographic data about, diabetes mellitus or glucose control. So definitely interesting, but again, it's, a few patients, the clinical relevance, I'm not too sure about. And another thing is that these guys did longitudinal incisions, and there are people out there doing bikini incisions. So, more in the creases of your skin, known as the Langer's lines. And I think there's some data in progress that may support that has lower complication in terms of wound healing than doing a true longitudinal incision, which is not, going in the lines, in the Langer's lines.
I also wonder, I don't know what about you guys, Sohum, but when you guys are closing your skin layer, are you guys stapling for your posterior, or are you guys running like a monocryl?
We do monocryl, try to get as tight. My opinion is that like if the wound is draining something out, it can track things in. We have plenty of attendings that'll do staples for hemis, and then some do for revision joints, but most people, I would say 80 plus for primaries, we're doing monocryl with Dermabond.
Yeah, we're the same here. We run everything, maybe for knees or revision cases we'll staple, but kind of similarly agreeing with you there. I think the running monocryl and then a Dermabond layer kind of, I think, adds to a little bit of a protective effect.
I think these guys, they did monocryl and dermabond. No, I don't think they did any dermabond, so I'm looking at it right now. Sorry, monocryl and steri strips. So, yeah, who knows? But again, just something to counsel patients on is wound complications.
Awesome. We'll go to the next paper here, guys.
We have our next paper. The title of it is "No Difference in Dislocation Seen in Anterior versus Posterior Approach, Total Hip Arthroplasty," and this was written by Marat and their team at Michigan, and this was published in 2016 in the Journal of Arthroplasty. Background information, we talked a little bit earlier regarding the dislocation rates of THAs, and it's roughly 1 to 3%. And dislocations are the most common causes of early revision. The most common approach with the THA is the posterior approach. However, the direct anterior approach is becoming more popular. One of the reasons why is because you're not splitting any muscle, and there's a perception that there's going to be an earlier functional recovery and reduce dislocation rates. So the purpose of the study is to compare the dislocation rates and secondary outcomes of the posterior versus the direct anterior approach of a total hip arthroplasty. This study was a retrospective analysis using a statewide registry where they had a lot of information regarding total hip arthroplasties between 2012 to 2014, and they included around 9,000 cases of the posterior approach, as well as roughly 2,000 direct anterior approaches. And these approaches were matched by age, gender, BMI, and ASA classifications. And in total, there were roughly 2,000 pairs matched up. So the results of the study show that there was no difference in dislocation rates based on the posterior as well as the direct anterior approach. With the posterior approach, there was a 0.79% dislocation rate, and the direct anterior approach had a 0.84% dislocation rate. And another finding was that regarding the OR time, the direct anterior approach was a little bit longer. So regarding the conclusion of the study, there were no differences in the dislocation rates or early outcomes with the posterior or the direct anterior approach. And so when you're thinking about doing the PA or the direct anterior approach, the most common one is the posterior approach, but the direct anterior approach is becoming more common these days. And so you can choose which one you would like. Regarding this study, it showed that the dislocation rates were pretty similar. Some strengths of the study was that we had a high quality registry, and we had a lot of matched pairs for the analysis. And we also had a modern technique, which included the soft tissue repair talked about earlier with the PA approach. And the biggest limitation of the study was that it was a retrospective analysis.
Nice job. I think one additional thing I'd just like to kind of comment here. I think one of the most important parts of, your post-operative care for these patients, beyond just doing the surgery, is educating patients on, their hip precautions, depending on what approach you went under. So if, I know the paper didn't really comment on that aspect of it, but I've noticed that, you do a posterior approach, and the next day you're walking into the patient's room and you see them, crossing their legs, and you're just like, man, you don't want to do that. So I think there's some importance in making sure you're doing a good job educating patients on, the appropriate precautions. So posterior approach, you're going over your posterior hip precautions. You're potentially, doing an abduction pillow initially for some, for a short period of time, and then when it comes to the anterior approach, there's a whole set of precautions as well. So, I think that aspect of it, I think also is very important, so that, patients are well educated on what they can and cannot do.
Yeah, I think this is well said. And, just I think a disclaimer on this article, Dr. Marat works in Indianapolis. I've interacted with him briefly. I don't know him well, and I've never been in the operating room with him, but one of our chiefs did his elective rotation with the group that he's with, and he's an anterior surgeon. So I mentioned to him that we were looking at this article, and I think that he kind of chuckled and was, fondly remembering at his time as a resident when he wrote this, and mentioned that I think they were hoping to find some superiority in the direct anterior approach and were surprised with what they saw. So pretty interesting. Stability was similar in both approaches, and it just kind of supports everything we've been hammering the whole time, the importance of your repair and doing something you're comfortable with.
Awesome.
And I think Kai, you mentioned this, and I just wanted to clarify. They said this in their paper as well in the 2014 American Joint Registry report, said that the most common cause for early revisions in total hips was instability. And I'm sure that was true at the time, but on the 2022 most recent AJR report, most common cause for early hip revisions is wound complications and infection. So I'm pretty sure that that's true with knees as well, but just something to remember. Generally speaking, early revisions in arthroplasty or for infection or wound complications, most likely. Instability is definitely one of the more common causes, but most common would be infection.
Awesome.
And we'll take it to I think our last one.
Yep. This paper is titled "Surgical Approach Significantly Affects the Complication Rates Associated with Total Hip Arthroplasty." It was written by Agarwal at NYU and published in the Bone and Joint Journal in 2019. So up to this point, studies had reported pros and cons of different approaches, but there was still no consensus on the best approach, as we were just discussing. So the authors of this paper aimed to compare the incidence of complications in 5 approaches: posterior, direct anterior, direct lateral, anterolateral, and northern. They did a retrospective review of primary, elective, unilateral total hips from 2011 to 16 after exclusions of conversions, revisions, and direct anterior approaches performed by low volume surgeons. They analyzed 3,574 patients. Posterior approach patients' mean BMI was 30.1 compared to 27.7 for direct anterior patients. The anterior approach had an 8.5% complication rate, and the posterior approach had 5.85%. The types of complication were similar amongst these approaches: 22% deep infection, 22% periprosthetic fracture, and 21% prolonged drainage, which was defined as more than 10 days requiring either negative pressure compression dressings or a change in anticoagulation. Anterior approach patients' reoperation rate was 4.74%, higher than 3.13% for posterior approach patients. There was no difference in the rate of dislocation or fracture between any approach, and anterior approach patients had the lowest length of stay at the hospital. So in conclusion, authors compared these approaches and found that the anterior approach had more complications and reoperations without a decrease in dislocation compared to the posterior approach, but the anterior approach did have the lowest length of stay. So we are still unable to crown a superior approach. As far as the strength of the study, authors emphasized their use of more accurate non-registry data. The study had standardized rehab, anticoagulation, and discharge protocols, but limitations include no patient-reported outcomes or survivorship data. Authors also excluded low-volume surgeons only for the anterior approach.
I think you're just seeing like another example of what kind of mentioned earlier. I think there's again pros for one and pros for the other, and then cons for both as well. There you could find another article that finds that there's no difference in complications and no difference in length of stay. And there's a little bit of selection bias when it comes to these studies. I think again, it's just important to really get across the point that do the approach that you're going to be most comfortable with. And one of the surgeon mentors I had in medical school told me, whether you do direct or posterior, just pick one and get really good and efficient at it.
Yeah, no, I definitely agree. And I think, these are pretty high or alarming numbers, a 20% periprosthetic fracture rate. I think it's important to know that a majority of these, I'm trying to find the exact number, occurred intraoperatively. I think 10 out of the direct anterior cohort were intraoperative. And I don't think this number is consistent throughout the data. I mean, I do know there's a higher intraoperative femur fracture rate with DA approach. But I don't necessarily think it's as high as 20%. So these are alarming numbers, but again, just be familiar with the complication profile associated with the approaches. And you know, I think Nigel mentioned all the approaches they evaluated in this study. I think because we have a couple of minutes, I want to just go through and clarify what some of that nomenclature means. So we've referenced you know, direct anterior approaches and posterior approaches, which most of you guys are familiar with at this point. But I'll just kind of go through it. Posterior approach, basically position patient lateral. It's, you know, Coker-Langenbeck's incision, where you start with your incision at the PSIS and you curve down the leg with kind of an anterior curve. And you want to, one way to check it is you can flex the hip up to 90 degrees and see if the line is straight. Once you get through the skin, you cut the IT band, glute max fascia, and you're looking at the gluteus medius. Usually put some sort of retractor underneath that, and you can see the junction of the piriformis short external rotators with the gluteus minimus, and a capsule deep to that, and you incise those structures, which is, you know, what Hassan referenced to when we mentioned that we need to cut muscle with a posterior approach. And then, you know, Hassan, if you want to kind of talk about just briefly your DA approach and how you guys do it at Loyola.
So yeah, like I would say at Loyola here, we're doing the direct anterior approach quite often and more frequently. In, you know, kind of saving our posterior approach as our main workhorse for revision cases or patients with, you know, have bigger BMI, that it's a little bit easier to approach the hip posteriorly. So the way we do it, obviously the direct anterior approach does require, you know, use of a special table. Here at Loyola, we use the HANA table. So obviously getting the patient, you know, set up on the HANA table is your first step here, and then obviously draping, and eventually you're gonna draw your incision. So the marker you're going to use to kind of start your incision is just kind of the ASIS. We tend to take about 2 finger breadths kind of lateral from that, or some people describe 2 to 3 centimeters posterior to the ASIS, and then extending that kind of towards the lateral femoral condyle, about 8 centimeters for male patients, typically maybe something small around 7 centimeters for you know, a female patient. So that's going to be your initial approach, and then you're just going to do this. It's essentially just a Smith-Peterson from there. And again, this is a you know, muscle sparing approach. So the advantage is, you know, you're hoping that the patient's recovery will be a lot faster. You can get up and moving a lot quicker. You know, it does require you know, that the hand table that I mentioned, and you know, we use a kind of this like lift attachment that kind of helps with bringing the femur up for when we are going to be broaching the femur. And I think that's where, you know, most people are concerned for this intraoperative fracture that may occur. So there is a learning curve with that. But I do think the obvious benefit is the, you know, direct visualization of the cup placement on fluoros that really gets you kind of, you can hone in on exactly the position you want, and you can confirm on it before you buy it. So I think that's where the advantage comes, is having that, you know, ability to have live x-ray. That being said, I think it's important to notice that I mentioned a lot of like prerequisites to the approach. So you're going to need, you know, a HANA table, you're going to need x-ray, you're going to need fluoro, you know, you're going to need, you know, different table attachments. So, you know, this may lend this approach to, you know, be one that's, you know, not as easily reproducible if you're not in like a big academic center or a place that has this availability, you know, of resources. So I think that's something to think about. But I will say, you know, you require less help when you're doing the direct anterior approach. I think you could get away with just kind of one assistant. Whereas maybe the posterior approach, you need either one really good assistant or at least two sets of pairs of hands to kind of get by. So I would say that could be another pro for that approach.
Great. Yeah. And then just kind of touching on 2 other ones that we mentioned were, you know, the direct lateral and anterolateral. And I think that there's a little bit of confusion even in the literature and on the nomenclature. And, you know, a lot of times people will refer to the direct lateral, anterolateral as a modified Harding approach, but basically, it's an approach where you are making an incision. If you're doing a true anterolateral approach, there's people that advocate that term only be reserved for a Watson-Jones, where you're finding the interval between the tensor fasciolata and the gluteus medius. And a more of a Harding or a direct lateral would be when you actually incise the tendon of the gluteus medius to enter the hip joint, from anteriorly, which is, problematic because you risk denervating the medius, which is one of your stabilizers, and can, give patients a Trendelenburg gait and lead to instability. But it is an approach I've seen some of our surgeons do it for primary total hips, and their patients do well. But just so you guys are aware that those other approaches are out there, so just sum things up. But overall, I think this is a good summary on the topic, and total hip stability is something that will continue to be debated, and there are things coming in terms of technology and spinal pelvic parameters, like I mentioned earlier, that are hopefully going to give us even more stable hips and reduce the instability for patients.
Awesome, guys. Good session. I hope everybody out there found this helpful and enlighten you a little bit more about the options of approaching the hip when you're doing total hip arthroplasty.